Hello, and welcome to Scholarvision. I'm Dr. Richard Becker, the director of the Heart, Lung, and Vascular Institute at the University of Cincinnati College of Medicine. I'm joined today by a very special guest, an internationally recognized cardiologist, Professor Josep Brugada. Dr. Brugada is a professor of medicine at the University of Barcelona, and he is the medical director of the Barcelona Hospital Clinic of Cardiology. Professor Brugada, we're going to be talking a little bit about discovery, and it's a fascinating topic to me because I never quite understand how it happens. Is it an iterative process? Is it something that is more incremental in nature? Or is it a high-level observation? So I'd like to use, as an example, your and your brother's discovery of the Brugada syndrome. So maybe we can touch upon some of the very early observations, how that in turn led to something that ultimately is described as a syndrome, genetics, and then lastly, how that can be applied as a screening tool and new treatments. So let's start with those early cases.
I think, thank you very much. I think the discovery by itself is a mix-up of things. It's a mix-up of accurate observation, trying to see things different of what everybody's looking at, and it's probably curiosity. Yes. You are curious, and then you try to find new things and new explanations to things that might be there and nobody have ever realized that they're there. And in fact, this was the case. The patients were there, the ECGs were there, but nobody has ever made the link between this strange ECG and sudden death. And we probably, our major contribution was to make this link at the very beginning of the observation. So we had this first patient in '86 that came to Maastricht to visit Pedro, and that was a 2-year-old boy with his father that has suffered sudden cardiac death that was recovered. And then we learned that the sister had died suddenly 1 year before. So then we could collect the ECGs of the sister and of the boy, and we saw that these electrocardiograms had a very strange profile, very strange morphology. And we, at that time, we just keep it. We treat the patient, the boy, with what we had at that time, was not an ICD. We could not implant an ICD on him at that time. That was '86. And then 2 years later or 3 years later, '89, it came to our attention another patient. This time was an adult patient that had suffered sudden cardiac death and was recovered also. That had an ECG which was extremely similar to the ones we have seen it with the child. And we were struggling there with Pedro, what is that, what is not. And then at that time, a fourth patient came to our attention. So when we had the 4 patients, then we present these 4 cases as curiosity, I would say, in Washington, in the World Congress in Washington. And then there we start talking with different people, and we came out with a group of 8 patients that had similar characteristics, and that was the initial publication. We never thought at that time that this was more than a curiosity.
Yes.
So we thought that we have come out with something which is rare, exceptional, but nice to publish. But what happened at that moment was a kind of explosion all over the world of physicians looking at the ECGs, identifying patients. Then we realized that the sudden unexpected death syndrome in Southeast Asia was exactly the same. The patients had exactly the same ECG, and then we start building up all the knowledge we had about the syndrome. And then two important things happened. One, in terms of the name of the syndrome, that finally in 1996, Miyazaki, for the first time, published a paper where he called Brugada syndrome for the first time. And since then, everybody's calling that Brugada syndrome. And second, in 1998, where we could study full family with 9 affected members, and we could for the first time make the genetic diagnosis of the syndrome.
Yeah.
So this was kind of closing the circle, and from clinical description going to the physiopathology and the cause, ultimate cause of the syndrome, which in this family was a mutation in the sodium channel, and this allowed to close all the information.
It's fascinating, the fact that you start with those cases with an unusual electrocardiogram, and that was a moment where you could have said, well, this is something that is unique, or it's just an anomaly, it's an artifact, but you didn't. You recognized that there was something about it that was unique. And then if I recall, the paper was in 1992 in the Journal of the American College of Cardiology, and then with that, people said, you know what, I've seen some of those cases as well. Let me ask you, as far as the genetic piece, so that's your Nature paper, what prompted you and your brothers to look specifically at that sodium channel gene, that SCN-A5?
Okay. At that time, so the initial description was done by Pedro and myself, that we were working together in Holland. And Ramon at the time was at the medical school, which is the younger brother. Then Ramon moved to the States, and he was working at Baylor, and he was doing cardiology and genetics with Bob Roberts. And so when we found this family in 1997, which was published in 1998, in fact, this family was followed in Barcelona and was studied in Barcelona. One of the things we were thinking is that we're having this right bundle branch block pattern. So we thought that it was something in the conduction system. Yeah. And many of the patients had a slightly prolonged HV interval. So we're thinking that this might have something to do with the sodium channel because of the conduction.
I see.
So and when we start thinking on when we get this family and we saw these 9 patients, we said, well, where do we start looking at, you know? And at the time we were discussing with Ramon and with others, and we said, well, probably we should start looking at the sodium channel because there is a conduction defect.
Yes.
And that was the right thing to do. And we found the mutation in this first family in the sodium channel, and since then around 30%, only 30%, but 30% of the families do have a mutation in the sodium channel as responsible for the disease.
It's fascinating that you put kind of the biology, the EKG observations into the right gene, chromosome 3 on the short arm. And if at last count there are 300 different mutations of that gene that seem to be linked. Right. I mean, does that surprise you how many different mutations there are? Or you say, no, that's kind of the way genetics actually is?
Well, that's kind of how genetics is, but it's true. But it's fascinating to me all the time that for me it's clear that every family has his own mutation. Yeah. It's fascinating to see that completely different mutations have the same final result, which is an ECG which is abnormal, which is ST segment elevation, which is this predominant ITO in the epicardium of the right ventricle. So that's so much thinking behind to arrive to the physiopathology, final physiopathology on how a mutation can finally make an imbalance in the ion currents in different parts, especially in the right ventricle, in the epicardium. Yes. And that leads to a specific ECG that might produce ventricular fibrillation. It's fascinating to me. And like how a mutation in the sodium channel can produce a completely different disease, which is the long QT3 disease, whatever, you know. So that's, for me, it's fascinating how we are learning. It's true that the monogenic diseases have allowed us to believe that genetics is very important to understand the physiopathology, but probably we are the lucky ones having monogenic diseases because, of course, the majority of diseases would not be monogenic, would be a combination of things, and would be much more difficult to arrive to a single pathophysiological mechanism that explains everything. But so far, in the so-called channelopathies, I think we have been very lucky The short QT interval is another very good example. The short QT syndrome that was described by us also in 2000. And that's again fascinating because we know at that time exactly what we were meaning when we saw the patient say, this is a mutation, a gain of function mutation in the potassium channel before we got the genetics.
Yes.
And it was exactly that.
That's a wonderful illustration of observations that lead to a very focused investigation. So tell me, and your humility is something that really strikes me for everything that you and your brothers have achieved. How do you translate that into day-to-day practice? Obviously, there are people out there with Brugada syndrome.
Yeah.
So part of the question is the screening piece and then the treatment piece.
As any disease description, the information has been evolving over all these years. At the very beginning, the 8 patients we described were all recovered from sudden cardiac death. Then we start realizing that it was asymptomatic patients with the disease that has not manifested so far as an arrhythmic event, but only as an ECG abnormality. And then we realized that we even could induce the abnormal ECG pattern by using some drugs. So we are forcing the diagnosis in some part of the population. So of course, this has a complete different background, and probably this is the wide spectrum of patients that might have a disease, some of them manifesting the disease dramatically with sudden death as first manifestation, and others having everything but never having a single syncope. Okay, so this has created some controversies over the years about how to identify the patients, about who to treat and who not to treat, and what is the best treatment. When we talk about sudden death, unfortunately, we don't have too many choices, because sudden death is there as a threat for the patients. And of course, when you talk to the families and you say that you have, 5% risk of sudden death in the next 3 years, then the people, and you have a normal heart, apparently normal heart, the people starts getting very, very nervous, and many of them will receive an ICD as a preventive therapy. So we have been trying all the time to understand as much as possible how to identify the proper patients, and this is very important because I can tell you that 80% of the consultations we are receiving of patients with Brugada syndrome that come to us for second, third, or fourth opinion, in fact, are not Brugada patients.
I see.
These are simply right bundle Rhines block, incomplete right bundle Rhines block, early repolarization, some abnormalities in the T wave, but not Brugada ECG pattern. So we are continuously explaining that because the diagnosis is based on an ECG pattern, this pattern should be very, very clear.
Yes.
And that's what we call the type 1 pattern. So you should not make the diagnosis of a Brugada syndrome if you do not have a Brugada type 1 ECG pattern. And this is something very important because you start scaring people and families just because of an abnormal ECG, which is not a Brugada ECG.
Yes.
And this then creates a lot of tension in the family, and then we have to deactivate a bomb that has activated somewhere else. So we are very strong with this message that only type 1 ECG makes the diagnosis of Brugada patients. It's true that many Brugada patients would normalize the ECG during follow-up. So you would have patients that would only have an abnormal ECG after unmasking it using antiarrhythmic drug, class 1 antiarrhythmic drug. This is true, and we have to be aware of that. So we are doing this test always that we suspect that there is a Brugada pattern. But if the pharmacological test is not positive, then we have to say, stop. This is not a Brugada pattern. This is not a Brugada syndrome, and stop any other or any further risk stratification, which is the second step. Once you have made the diagnosis, then you have to risk stratify. And you have to be able, at the end, to tell to the patient, look, you are at very low risk, you are at medium or high risk. Because if you say that you are at medium or high risk, normally the final recommendation would be to implant an ICD.
Yes.
If you are at very low risk, you have to be very strong in your conviction to say to the patient, look, you are at very low risk, we have to do nothing in you. Because if you are doubting on that, then we have problems because, of course, the patient feels that sudden death can happen anytime.
Yes.
And this is one of the most strong message we have to give to the patient when we strongly believe that he's at low risk, which happens in more than 70% of the cases we are seeing with no previous symptoms. These patients are at low risk, and we are doing that. And, again, there is a worldwide controversy about that. We are using EP study, program electrical stimulation, to see if we can induce or not arrhythmias in these patients, and we trust a lot the results of the EP study. If the EP study is negative, then we are quite confident that the patient is at very low risk. So we try to translate all this information to clinical practice, which is always a very complex consultation with the families, especially if there are kids in the family and if the parents are affected and then they are very much worried about the kids, etc., because of the genetic nature of the disease, and you have to be very strong in the convictions and how you explain the things to make sure that they understand the risk-benefit of each one of the therapies.
Yes. Well, thank you so much for joining us today, and congratulations to you and your brothers on an incredibly important observation, and beyond that, how it can be applied and translated. It's something that the medical community owes a debt of gratitude to all of you.
Thank you very much. It's a pleasure to be in Cincinnati.
Yes. And thank you all for joining us today on Scholarvision. Until next time, keep asking questions. Inquiry is the true compass of scientific and medical advances.